So we did have time for closing remarks and for anything else that people want to discuss. I want to first thank all of our presenters that came today and everyone in the audience and that has joined us online. So I think I also want to thank Adam and Marjorie who have been moderating the chat and for helping us through some of the AV issues we've been having today. I think the technology in this room was like state of the art probably like 10 years ago, and the way that technology moves is like, it's too bad. But also, this is not a huge meeting. We don't have 200 people here, but that doesn't mean like organizing the logistics is any less. So big thanks to Teresa for organizing everything today. The food, the agenda, all of the AV. This stuff isn't easy to do. And like I said, just because it's a smaller room doesn't make that any simpler. So I did want to just highlight the fact that we try to get every type of partner that we jammed into this agenda, right? So we talk about epidemiology. Thanks, Dr. Reed. No problem. Epidemiology, laboratory, immunizations. We have provider stories. We have our payers. I didn't want Dr. Reed to feel like she was getting thrown to the wolves here, but we talk about harm reduction, and then of course having the public perspective, the client perspective, someone with lived experience is really, really important. And so I wanted to make sure that we always try to highlight all of those different disciplines because they're all really important in their own respects. I did want to also thank Adam, Marjorie, Kim Kirky, who's part of our surveillance team that's putting this annual report together every year. It's dozens and dozens of pages long. We hope that it's meeting everybody's needs. Of course, if there are other things that you want us to include in the future, we're always happy to do that. If you have data requests of us, we're always try to make that available to you. I know Red Project has asked us at least a few times to help us provide data to them to justify the need for SSPs in a certain jurisdiction, or where would be the most effective place according to the data for us to put a location or a location for a mobile site. And we're always really, really happy to be able to sort of triangulate different data sources to help you guys make a case. Just as a reminder, our annual report's going through the approval process right now, so should be available within the next few weeks, and we'll of course send that out to everyone via the various listservs that we have. One of the things that I've heard in a conference, a representative from the CDC say, and I don't always agree with the things that they say, but this one kind of stuck out to me, and he said that every person that's living with hepatitis C is a failure. And it's a kind of a little bit of a profound statement, but I think in many respects it's true. We didn't do a very good job, the collective we, of preventing these people from getting infected in the first place, even though that we know that there are effective interventions. And people that are infected with hepatitis C, there's a cure, and if you're not cured, we're failing them on some level, whether getting them tested, linked to care, approved for treatment, on treatment, preventing them from becoming reinfected. And so obviously we're working towards ending the epidemics, which I think is a really, really lofty goal for hepatitis C. But I think there are really good examples of micro-elimination strategies, at least that's kind of what I'm referring to. So you think about individual clinics like we have in Muskegon or Saginaw, where they can really probably demonstrate that they can eliminate hepatitis C in their patient population in the future, maybe even the near future. The VA is a really good example where they've had a lot of investment, but with that investment, they are planning to eradicate hepatitis C in the veteran population by the end of this year, which is just absolutely incredible with the amount of the prevalence of hep C in that patient population. So to that end, I just wanted to mention at least a few activities that our group hopes to be involved in the future, just to give you an idea of what we hope to do and think about how you might be able to help be involved in those projects. So one is related to microelimination strategies. We would, in collaboration with the HIV group, we'd like to hire within the next fiscal year a linkage coordinator for hepatitis C. which I think this person may focus mostly on the co-infected Ryan White population, HIV co-infected Ryan White population to start, because I think this is a population we can really demonstrate Hep C elimination in, people co-infected with HIV, where there's less barriers to getting individuals treated. I think eventually we'd like that person to evolve into someone that can manage linkage to care for hepatitis C mono-infected persons once the investment for that comes. I don't know how many times we get asked, like exactly what you said, Pam, is like, oh, I have this person that's positive. Where can I send them? And I mean, this is our prevention program is Teresa, so it's like, I don't know. We don't know. There are some great examples in certain cities where we know where we can send people, but that infrastructure is not available anywhere, and we don't have the staff time and resources to be able to find those navigation pathways yet. But if we had a person that was specifically dedicated to that, I really feel like we have the opportunity to find what those regional pathways would be like to help streamline getting people through that cascade. Harm reduction is another like really fast growing area where there's just been a ton of movement. I think there's probably people in the room that would agree. We've had more movement in harm reduction in the last like 6 months than we've had in the last 6 years combined. So and that has to do, I think, a lot with MDHHS and the leadership that we have in place now that are really sort of doubling down on all of our efforts. And the data case that we can make with hepatitis C and HIV and other infections are really helping to sort of drive that. And so I do want to emphasize for our folks that do the nitty-gritty data stuff behind the scenes every day that really is paying off in a lot of those data products, making the case to the people that are in our administration. And we've been working very closely, and one of the great success stories I think recently is Dr. Wells gave a presentation to Governor Snyder's opioid commission related to infectious diseases associated with opioid use, and there was unanimous support on that panel for support of harm reduction and syringe services programs. And that's something we've been trying to get on their radar for some time. Thank you. And so that's super exciting. And there was a formal motion that was approved in a letter that's going to go out to all health officers saying that the Opioid Commission supports expansion of syringe service programs. So I think that's going to go a very long way. Related to that, I've been saying just because you have this sort of support for verbal support for syringe service programs doesn't necessarily make it so they just happen automatically, right? You need resources, you need financial support for those things. And we've been working with other areas of the department that have money to help them rededicate some of that money towards SSPs. And we're excited to hopefully announce very shortly that there will be some money coming down the road in the next fiscal year to support at least some local jurisdictions to expand or start new syringe service programs. We'd like to fund every community in the state of Michigan because each community in the state is affected by opioids and hepatitis C and other infectious diseases related to the opioid epidemic. We're not quite there yet. We don't have that budget, but we have enough to at least support some new programs in the near future. Related to that, though, I'm not a harm reduction expert. Teresa's not a harm reduction expert. I don't know that we have any harm reduction experts. I'm glad that we got a little bit of the patient perspective today, because it does, we know, we're very conscious that we're not experts in that area. And we do hope that with some of this funding, we're able to hire a harm reduction specialist, maybe someone with lived experience to help us navigate these new programs and sort of help us develop those programs in a way that's culturally competent and makes sense. So we're definitely trying to increase our capacity in that respect as well. I think that's all that I wanted to say. Laboratory is also awesome. I'm going to highlight that again just because the molecular stuff is really cool. I'm excited about that and to see how that could maybe help us. We don't have a lot of resources always for targeted prevention. And so when we have to really develop a framework for how to focus our very limited sort of prevention efforts. And I think the molecular stuff really helps with that. And so when we have something that we can target instead of trying to figure out where to go in the entire state. But I will say, and Pam is submitting isolates to our state laboratory as part of a formal partnership with MDHHS in her program. And so I do want to highlight again that our lab can do hepatitis C antibody and RNA testing at no cost to our public health partners. It does require phlebotomy, so that's one thing that you have to keep in mind. But there's no formal certification for phlebotomy. You just have to go through a training, and it can be done. All the specimen shipping materials, collection materials are all available free of charge. And there's no special reporting that you necessarily have to do to the state health department. Everything gets put into an electronic database for us to see, so there's no additional reporting requirements. So it's really easy. You can ask Pam. Please submit to the state lab if you want to. You don't have to. So with that, those were my closing remarks, and I have any PowerPoints. I do just kind of want to open it up to anyone that has any specific questions, comments about what I talked about, or for any of the other presenters that might still be here and can help answer any questions.
I have one comment, and especially your question brings it up to me. So we have been working really hard with, let's see, so our CEO, our president is, she's part of MP, Michigan Primary Healthcare Association.
MPCA.
MPCA,
Michigan Primary
thank
Care
you.
Association.
Okay, so we have been working hard to, just like my talks, to just spread around how easy it is to incorporate the Hep C treatment. And now, you know, there used to be all these barriers we could name off. Cost of drug was the big thing. Now it's, like you mentioned, it's having a specialist to sign off. And we actually were working together because we were saying we'll do everything we can to help. Dr. Gulick was on board. He's like, hey, I'll sit and phone consult. You talk about telehealth. It's a wave of the future. And the barrier to that was that Dr. Gulick was willing to do it, but MSU is not so open to renegotiate his contract and give me 2 more hours of his time to say he'll sit on a computer and he'll consult with MPs and whatnot. So that's a barrier that it's just frustrating. But anyways, I think if we think about it, we've got to think out of the box, but if we think about, because we spend money here, we spend money there, but what if we could recruit a handful of specialists that are willing to consult, that we don't have to fight their contracts with private whoever, and just say, okay, I will consult with a clinic, telehealth, or over the phone, or over the computer, with your NP, with your PA, with your physician, who's a non-specialist. And we could think about, to me, to pay that time for a specialist to, and I agree, like she was saying, not all specialists are willing to say, I might be putting my license on the line to, that's why we set up criteria. Our criteria was that if a health center wanted to implement the program, they first had to come through, train with our nurse, model after our program, sign a contract with us, say you're going to use guidelines, you're going to follow these policies, and you're going to consult with our physician, you're going to train with us, and say, okay, so I feel like for a relatively low cost, if we could get a handful of specialists to agree to oversee these programs, even if they're in community health centers, rural, however, that we could really move forward with this. And so just a thought. I'm always throwing my thoughts around. Sometimes they go nowhere. But I really always try to do things. I do. Like I said, I can't ask for things enough, and people are just going to say no, but sometimes they say yes. But just as a thought, instead of trying to do this and this and this, maybe we could just find a couple of providers that would say, I'm willing to contract, and go that way.
Yeah, I mean, the prescriber restrictions to me are maybe the biggest barrier that we have right now, actually, with that list. I mean, the sobriety restrictions a little bit, but I mean, yeah. I think there's some flexibility, like I said, in improving some of those meds. But yeah, so I mean HIV, right? You guys have a work with Henry Ford for.
Well, I mean, I was just going to really disagree with you because I mean, we don't have provider restrictions for HIV. And HIV is also very easy. And the reality is doctors don't want to treat.
See, and I don't agree that HIV
Well,
treatment's easy.
It's not easy,
It's
but
complex.
it can be done.
Yes.
It can be done, I think, yearly in some sort of modified primary care setting. For simple
I agree with that.
And we try to call doctors in rural areas, and we will pay them. We have all the money in the world. We can do telehealth consults with them. We go there, we're sending people there, and they don't want to do it. They don't want the clients. And I have very profound concerns that Dr. Gulick himself is single-handedly the only person that cares about Hep C now. And Dr. Gulick is probably going to need to retire one of these days. Maybe soon, right? And so I wish that we could take a step back almost to think about like medical school or advocacy or nurse. There's frequently, we're looking now at LGBT medical students to try and say, there's not enough people that care. Could you be a person even in medical school to start a group?
I have names. If you, I mean, I literally work and I work with so many residents and so many medical students, and we recruit them into, matter of fact, we just had one rotating in our clinic, Dr. Weeks, that his focus is, yeah, we want him, his focus is, he came to me, he met me on LinkedIn and came to me and said, I'm here from Boston, I'm interested in LGBT, Hep C, HIV care. He's an internal medicine. And he is like wanting to do this. When we bring residents and students through our clinic and they see how easy the treatment is, it's like they're like, oh, we can do that. And Dr. Gomez down in Jackson, he's like, I am taking all of my residents through our Hep C program so that they can see this is easy. This is something you should be doing. So I really do think it's something that Hep C treatment is so basic and easy that we can get people on board. And I agree, reaching out to the schools, getting these students involved, getting them in. And we have people still coming into our clinic. We just had one that our CEO thanked me. She said she was a student who rotated through your clinic, and now she's working for Great Lakes Bay because she was so impressed.
I think there
And
are
so
going to be
we need to do this.
nurse practitioners, PAs, medical students who are going to have been affected by the opioid epidemic and have seen their parents, cousins, aunts, uncles, themselves. And harnessing that, like in terms of advocacy, medical advocacy groups, might be an opportunity for
To come back to this topic, I forgot one other really important announcement is that there's cookies like right on the other. So as you're leaving, because we want everyone to have a nice drive back to wherever it is that you just take a couple of those cookies with you, please. But we have, Teresa has been thinking about trying to figure out how to put together some sort of coalition. If you look at some other large city health departments or state health departments, they have really robust hepatitis coalitions, which I would suggest not be run by the health department, but run by some other agency with contributions from the health department. We have kind of tried to reach out to people to bring a group like that together, and we just haven't been able to find the right people. But if you have suggestions for persons that would be valuable to have on sort of a multi-discipline sort of coalition, we would love to have that info to be able to reach out to them to maybe one day make that happen. And I think something, to do some advocacy. We would love to advocate. We just can only, we have certain restrictions, and we try to share as much information with Medicaid as we possibly can. We know like the hepatitis C treatment outcomes are just as good in persons who have a substance use disorder diagnosis versus those that do not. And so being able to share the science and the data with them is kind of where we're at. But if there are other folks outside of the state health department that could help make the case to the people that are the decision makers, it would really be beneficial. I mean, we would definitely see the benefit of that. So yeah, I mean, you have persons' names and contact info that are going to be really engaged. Send them to Teresa, please. Anything else anyone else wants to talk about? Otherwise, oh, Steve, yes.
So I'm always struck by that graph that you showed, the one that showed the year of people's birth and the number of Hep C cases based on people's year of birth. And I guess the point that chart was showing is that people born in the 80s, that age group is approaching the number of cases in the baby boomer generation, and there's the CDC recommendation for once lifetime tests for baby boomers, and with the stigma that we know that exists around injection drug use and around discussing injection drug use with your medical providers. I wonder if it would be wise for us to just move to universal screening for hepatitis C as opposed to risk-based.
Yeah, so I think it's coming. I don't have any particular knowledge of that actually happening, but I just have a feeling, especially the AASLD just changed their recommendations to suggest that any woman that's pregnant be tested for hepatitis C. And I think that's basically in a birth cohort recommendation. Anyone that's a woman that's of childbearing age years should be tested for Hep C, basically. And men of that age have just as much risk as the women do. So I mean, I think that is probably going to be something in the future. And I know that the United States Preventive Services Task Force has their hepatitis C screening recommendations open right now for like public comment. So I'm wondering if there might be a change coming with that related to universal screening.
I just have a comment on that too, though, but not even just universal screening, but I mean, if a person is using substances, I guess, Larry pointed it out, but I had a similar experience where I was going to get tested because I was in recovery, and that was what I was going to do. I was going to go get tested, and they handed me a cup to pee in, and I was like, "How are you going to test for hepatitis C with this?" And they said, "Oh, well, that's you have to specially request that test." And I was kind of surprised that admitting that I was an injection drug user, and that in my concern, because everybody that I was using with had hepatitis C. So that's what I was like going there for. And then they handed me a cup. I was like, okay, well, so, I guess, okay, I'm specially requesting. I don't think that I should have to specially request this test to be done. So, I mean, even if it's not like universal, just more, and Larry had the same experience where like, okay, so maybe I'm not admitting that I'm an injection drug user, but it's suspected, or I mean, I guess you can't really single people out like that, but I just in running a syringe access program, I'm amazed at how many of my participants they don't know their status when it comes to hepatitis C, because they've just never been tested, and it like amazes me that it's not.
Yeah, that is pretty sad. And I mean, to Steve's point also, I mean, if there's a universal recommendation for screening, that probably helps a lot to reduce stigma. And it's like, oh, well, why are you testing me for Hep C? Test everybody. So, and I think there are efforts to routinize Hep C testing as much as possible, making that integrated into electronic medical records and things like that. So those orders are automatic and not generated by a person having to click a button or something like that to get that test ordered. We hope that becomes more common.
I'm curious, is there a way for the state lab, like, can you think of a way for us to be a better partner? Because again, as Dr. Sunland keeps saying, we have this testing available. We can do it. I mean, this is what our state tax dollars are paying for. We keep saying it's free. It's not free, it costs, but this is what our tax dollars are supporting. So how can is there a way for us to be better partners or get the message out
I mean,
to other people? Or?
I mean, the couple of things that I've heard from the community that like submitters to the lab, they'd love for the RNA test that the lab does to be a viral load test and instead of just a qualitative positive negative, because they will, like for prior authorizations, folks may want to see a viral load test. And then if there's any way in the future to do that sort of next step, the genotype step at the laboratory, problem is it's not really a diagnostic test. That's becomes sort of a clinical thing. And of course, those are going to be a little bit more expensive, but if the cost can be sort of eaten by the lab for those sorts of things, I think that's something that
Or
would
can
be.
we, with some things, again, I'm new to the virology section, but things that we can think about or look into when I start to go on the calls and stuff. Yeah, I mean, it does, everything has a cost, and, you know, I think as the person from Medicaid said, you know, let's take money from here, or that goes away from there, and just figure it out.
And with the drugs that are out becoming more pan-genotypic, almost we may negate the need
That's
for genotyping pretty soon because the drugs are going to treat every genotype.
Well, and the other thing for us is that so many people are so seriously immunocompromised that if we can get a blood draw that could actually give us a viral load, if we can get that information from the one successful blood draw that we got, you know, that is already huge. You know, it's an anxiety producer in a portion of our population, just the idea of having to have labs, because it's not just the idea that they're not going to be able to find a vein, but it's that the whole how a person gets treated when they submit themselves for lab testing. And although many times the medical professional is well-meaning, you know, there's a lot of shame already going on in that person's heart and mind anyways, and then they present for a lab draw and somebody will say something that, well, why would you do that, or whatever, and although it's well-intended, it's a challenging thing for folks to get a lab draw.
Mm-hmm.
That's the other benefit of being able to get that information from the one sample.
Or even if we could get access to rapid tests to the state. In a lot of these cases, I mean, if we have somebody who we can't, phlebotomists in-house can't gain access, we send them to the hospital, and a lot of times we just lose them. They don't make it in the hospital lab, and whereas they could at least left our office with some bit of knowledge to hopefully in the future come back for care, they go back into society and never return again. And that's a missed opportunity.
Yeah, I mean, so as far as rapid tests go, we're not really allowed to purchase them with the limited amount of federal funding that we get. But there are different agencies that we've been trying to collaborate with that can provide those rapid tests at low cost or no cost. So we've been trying to sort of make connections, be the sort of facilitator to get the community partners engaged with the folks that actually can provide those testing or the rapid tests. So we have that contact info. If you want to get in touch with us, we're happy to do that. All right. Teresa, do you want to say anything else?
Before you guys all leave, I just want to say thank you again for coming, and for those of you on the webinar, thank you for attending. In addition, I would really love it if you guys filled out the evaluation survey that I'm going to be sending out to you guys via email. It's really helpful, that feedback for next year. Like if you want to complain about the sound and stuff, you can just write that on there as well. So it's really appreciated. And again, I hope you guys have safe travels back home, and thank you, and hope you guys can join us next year. Oh, and Joe mentioned, don't forget the cookies. Thanks so much, guys.